everyone, and we are now going to move on to the white blood cells and also the lymphatic system. I put this here because it's a nice bridge between the end of the hematology system and the start of the immune system, which we're going to be talking about next week. And this is a nice kind of bridge because the lymphatic system is involved in both. So kind of nice lead into next week when we cover innate and adaptive immunity. From that multipotential hematopoietic stem cell, we are going to be focusing on myeloid progenitor, but we're going to focus here on the myeloblast. And it's going to differentiate into either a basophil, neutrophil, eosinophil, or a monocyte. We're also going to take a look at the lymphoid progenitor, which is going to go into natural killer, and your lymphocytes will then differentiate into either a T lymphocyte or a B lymphocyte. So we're really looking at both lines off of the stem cell. There are myeloid and lymphoid in the white blood cell system. So we do talk about both lines. So first up, we're going to talk about the leukocytes, which are going to be off of these myeloblast, and it's going to give us our typical basophils, neutrophils, eosinophils, monocytes, which then differentiate into either a macrophage or a dendritic cell. All right, leukocytes starting points. So it occurs via a stepwise maturation, and what we have are CD34 stem cells. They arise in the bone marrow. Remember, pretty much everything starts in the bone marrow, and then we have those two lineages, myeloid and lymphoid. If we have problems that are showing a decreased or increased production, always think bone marrow. Or is there a potential for accelerated destruction? Usually we have neoplastic syndromes that encompass most of the dysfunction within the hematological system. There are some others. And then we do have some non-neoplastic that can be congenital or acquired. So we look at leukocytes and we break it into granulocytes or agranulocytes. And it's basically broken down into granulocytes. Do have a lot of granules inside their nucleus, and those encompass neutrophils, basophils, and eosinophils. The agranulocytes, meaning they don't have a lot of granules inside, those are going to be our lymphocytes, monocytes, and macrophages. If we have a deficiency, a quantifiable deficiency or increase, then we're looking at leukopenia or leukocytosis, and here are your numbers. Leukocytosis is greater than 10,000 and leukopenia is less than 5,000. Basically what happens if we have leukopenia or leukocytosis, there is going to be ultimately a disruption of function, whether it is immature blood cells that get out into the bloodstream. Again, remember, we need cells to do their job. So if they are immature and not able to do their function, then we get disease. So we're going to take a look at granulocytes first, and they have many membrane-bound granules within the cytoplasm. So here they are, and you can see all of those granules. Those enzymes and granules are capable of killing microorganisms and catabolizing debris during phagocytosis. We talked about phagocytosis back when we were in cellular biology. This builds on that concept. That is what these guys are in charge of, making sure our immune system is working. They have those powerful biochemical mediators that respond in inflammatory and immune, and they can be triggered by innate as well as a specific stimuli. All of them have amoeboid movement, which is called diapedesis, and move through the blood vessels, through the walls, usually to the site of infections, inflammation. First up are neutrophils. They are the most abundant. We also call them polymorphonuclear neutrophils, or PMNs, or segmented neutrophils. All of them are interchangeable. It takes about 7 days from those early precursors down to maturation. So here's an early precursor, about 7 days to get down here to differentiation. What is the function of the neutrophil? It is a primary defense against bacterial infection. They are the first to the party. So they are going to be a main player in phagocytosis and digesting and ingesting those microorganisms and really getting rid of them. Neutrophils respond to several sources of chemotaxis. Chemotaxis is another cell or cytokines, interleukins, some other portion of the inflammatory response or the innate or adaptive immune is basically saying, hey, there's something going on here. We need the fighters. So they will send out chemical messengers, and that is called chemotaxis. We respond by leukocyte neutrophil activation by macrophages releasing interleukins, basophils and mast cells releasing histamine, and C-reactive induced complement activation are all ways that we get chemotaxis for the neutrophils to come on down to the party and do their job and get rid of a bacterial infection. So just remember that these have a 3 to 5 lobe nucleus, and then we have that cytoplasm that has all of those fine granules. When we talk about driving forces of neutrophil activation, it is bacterial infection. And remember what we talked about back in cell injury and death. Necrosis is always followed by acute inflammation. So necrosis is another driving force of neutrophil acquisition, bringing it to the area. Other will be high cortisol states. We have two groups of neutrophils. There is one group that ends up in the circulation, and the second group is called the marginal pool. Here, so we have that bone marrow differentiation. We get bands and segmented cells, 7 days. Then we have a marginal pool, and these are in the spleen. We also have some in the lung and the liver. They are segmented. So these are the full-blown segmented neutrophils. We also have the circulating pool. So this would be in the blood vessel. What's interesting about this marginated pool is we talked about the steroid response. So these guys basically hang out on the endothelium and kind of have adhesion molecules. And they're kind of just, hanging out there. What happens with steroid hormones is they break these bonds of the adhesion molecules, and it results in them being put into the blood vessel, and that's where we get increased leukocytes and leukocytosis from steroids. So when we talk about the shift to the left, so here we have left to right, and when we talk about a shift to the left, we mean that we're going backwards, and that basically is where we get this band neutrophil, which is an immature, also known as stabs. Next up are eosinophils. So these have large, coarse granules and constitute only about 1 to 4% of the normal leukocyte count in adults. They are also capable of amoeboid-like movement. They are from the bone marrow, from the myeloblasts. These are all from the same line. The granulocytes, neutrophils, eosinophils, and basophils are all from that same line. They use pattern recognition receptors, and they ingest antibody-antigen complexes and viruses. They respond to mast cell basophil chemotactic factors. They have these highly aggressive secondary granules, and they are toxic chemicals, and they are very destructive towards parasite and viruses. And here's just a couple of them. Major basic protein, eosinophil cationic protein, EOS peroxidase, so there's one of those peroxidases again. And then we actually have an EOS-derived neurotoxin as well. They contain pro-inflammatories such as leukotrienes, prostaglandins, platelet activating factor, and then they also contain anti-inflammatory enzymes such as histaminase. Next up are basophils. They comprise less than 1% of the total leukocyte population in an adult. They also have cytoplasmic granules that have an abundant mixture of biochemic mediators such as histamine, bradykinin. Other ones would include prostaglandins, leukotrienes, and then they also have chemotactic factors that attract neutrophils and eosinophils. Stimulation of basophils induces vasoactive lipid molecules, and that is these new. So this process here to get these new mediators is this here. Stimulation of basophils basically leads to synthesis of vasoactive leukotrienes and cytokines. The cytokines include interleukin 6, interleukin 10. This is by way of T helper 1 and T helper 2 cells. that favor B cell differentiation. So like I said earlier, this stuff is all linked together. And then that guides B cells into secreting IgE. Basophils are often increased at the sites of allergic reactions. There's also a response to things like ectoparasites such as ticks, also hypersensitivity, IgE hypersensitivity reactions. All right, so let's take a look at another white blood cell, but it's kind of specialized. But since we're getting ready to do immunity, let's talk about the mast cell a little bit. You will not see this on your differential. This is really more involved in inflammatory response, but because we're doing cell classifications and definitions, just wanted to show you where it comes from. So it's off of the myeloid progenitor line, and then it is its own cell line. So mast cells are very unique, meaning that they are their own things. They produce off of the myeloid progenitor. They are not differentiated from a myeloblast. Mast cells are really kind of neat. They really have a central role in inflammation, and we'll talk about that next week more in depth. But they basically respond to really any insult that happens within a break in the skin, an inflammatory response. And they are also involved in healing, as you can see here with fibroblasts. So they take care of inflammation, but they also then are involved in healing. This is one of the big things next week when we talk about the innate reaction, where we have that increased permeability of the blood vessels and smooth muscle contraction. That is related to the mast cells releasing cytokines and histamines. Also, they will release heparin and some other enzymes that are heavily involved in this inflammatory response. They usually reside in the vascularized connective tissue, so pretty much right under the surface of your skin is where we're going to see all these little mast cells. They have a similar action to basophils. So when we look at kind of all of those mechanisms, really allergic response, inflammatory, that's high yield with the mast cells as well. Now we're going to move on to the agranulocytes, which are the monocytes and the lymphocytes. So now we're over on this side. So the agranulocytes are the monocytes, macrophages, and lymphocytes. So now we're down here and here. So they have less granules in the cytoplasm. So you can see the difference between the granulocytes and the agranulocyte. We have monocytes and macrophages are larger and fewer digestive vacuoles than the granulocytes. Lymphocytes do not have any enzymes to digest. So first up are the monocytes. This is part of the mononuclear phagocyte system, also known as the reticuloendothelial system or macrophage system. So either one of these is interchangeable. They mean the same thing. What this means is it consists of specialized endothelial cells in the bone marrow, spleen, and lymph nodes. So basically you have bone marrow makes the monocytes, and then it's either going to go macrophages or dendritic cells. If the macrophages get into the tissues, they're called something else. So if it's in the lung, we call it alveolar macrophages. If it's in the liver, we call them Kupffer cells. If it's in the spleen, they're in the red pulp. If it's in lymph nodes, we call them medullary macrophages. So they all have different names based on their locations. So after they get into the tissues, they're called macrophages or dendritic cells. So blood and tissue. So they migrate to the variety of tissues, mature into tissue macrophages or dendritic cells. Other monocytes are circulating macrophages. The dendritic cells look different than the macrophages. The dendritic cells have those arms, okay? Not to be confused with the dendritic cells in the neuron system. Dendritic just means arm-like projections. Once they leave the circulation, they do not return. The exact turnover is unknown. They can live months to years as far as we're aware of it. Monocytes have a horseshoe nucleus.
So let's take a look at macrophages. So macrophages, their normal role is to remove old and damaged cells and large molecular substances from the blood. So they're basically the cleaners. They have cellular targets of phagocytosis. Remember, we talked about phagocytosis before. Macrophages are huge in phagocytosis. And they also have a large role in circulating senescent or damaged erythrocytes and platelets, and then that's primarily removed via the spleen. Dead neutrophils in the circulation and the site of inflammation, and then cells undergoing apoptosis. So they're heavily involved cleaning up the mess. So huge in keeping that cellular housekeeping, overturning, and making sure that everything stays cleaned up. Non-cellular targets include antigen antibody complexes, and that's going to be huge for our immunity. They are huge in APC, which is antigen presenting. So these guys are big with adaptive immunity. The dendritic cells are the other major antigen presenting cell. Basically what happens is we ingest that microorganism and then they break it down, and then they basically take a little bit of the antigen and express it on top of the cell surface, and the CD4 T cells, CD8 T cells will then recognize it, and that's how we get our adaptive immune response, and that's how it's specific to antigen. And again, this is just kind of an introduction to these cells. We're going to be going much more into it when we get into immunity. They are also present in innate and adaptive, and they are kind of that bridge. So they represent a key feature of that. Remember that the dendritic cells have those arm-like projections. All right, and that's how you can tell them apart from the macrophages. Lymphocytes. So these represent 36 of the total leukocyte count. They are present in the circulation and lymphoid organs. They are the primary response for the immune response when we're talking about adaptive immunity. Hardly any of these are present in acute inflammation. They circulate and reside then in secondary lymphoid tissues as mature T cells, B cell, plasma cells, and we'll talk about that more when we get into adaptive immunity. They do not contain any enzyme-filled digestive, so no enzymes or digestive vacuoles. All right, so there's none of that in lymphocytes. The span of the life of a lymphocyte is days, months, years. This is what gives us our long-term immunity. They develop from precursors in primary lymphoid tissues, either the bone marrow or the thymus. We get B and T cells and its progeny. We get clones, and they express a single antigen receptor. The total population of lymphocytes is huge. Tens to hundreds of millions of antigens they will recognize, but each lymphocyte recognizes one antigen. It's absolutely crazy when you think at the breadth of coverage that these lymphocytes give us. The immune system is just amazing and requires respect. Just awe-inspiring how the body protects us from invaders. So the B lymphocytes, they are from the bone marrow, and that's actually where we get the B from. So bone cells produced in the bone marrow, B lymphocytes, they undergo immunoglobulin arrangement, and this is all DNA determined. They are naive B cells that express IgM and IgD. B cell activation occurs, and then they become either a plasma cell or a memory cell. So memory B cells, this is where we present that antigen, okay? So we have an antigen presenting cell, we present the antigen, and then we get memory to that antigen. So whatever microbe, virus, whatever, that's where we get memory B cells. The plasma cells are basically our antibody factories. So we get that presentation of what the bacterium is, and we ultimately will get memory to it, and then we will also produce antibodies. So that's what these are. So we have memory cells and we have little antibody factory cells. So once this happens, this is where we get that flood of antibodies in the immune response, is from the B cells. Very important with being able to fight off. The other lymphoid tissue is T cells, and this is involved in the cell-mediated or cellular immunity. So bone marrow as progenitor T cells, and then they migrate to and develop in the thymus. T cells, thymus. Okay, that's what they're named for. They undergo a rearrangement, and they get a T cell receptor. This is also unique. Then the progenitor cells will evolve into either CD4 T helper cells or CD8 cytotoxic T cells. So these are cell-killing cells, and they're involved with killing those invaders. And then the CD4 cells are what basically help us with the immune response. So you can see here CD4 cells, and they help B sites become activated and create memory B cells and plasma cells. So T cells and B cells work together to give us our immunity. The T cell receptor is the surveillance for antigens and recognizes the major histocompatibility molecule. We'll talk more about that later. So it recognizes antigens on the surface of the macrophages. That is that antigen presenting cell. The elimination of virally infected cells, tumors, or foreign bodies, release of cytotoxins to kill. And then they are also involved in delayed hypersensitivity reactions. Next up are natural killer cells. So these resemble large granular lymphocytes. They are different. If we go back to our schematic here, now we're over on this line. So we get common lymphoid progenitors. Here's those B cells and T cells off of the lymphocytes. Now over here, we get natural killer cells. So you can see that they have a granular appearance to them. The B cells and T cells do not have any granules. So now we have these large granular lymphocytes known as natural killer cells. They are in the bone marrow, and then in the peripheral blood cancer cells, and they also are huge for virus infected cells without being induced by a previous exposure to antigen. So that's high yield. It basically means that they don't have to be exposed to something to elicit a response to it. That is why their name is natural killer cells. And that's why they are differentiated from cytotoxic killer cells, which are induced by antigens. So different there. All right, so this is the difference. T cytotoxic cells must be activated by antigen differentiation. Natural killer cells do not need previous exposure. They also have the capacity to activate T cells, phagocytes, and produce a variety of cytokines that regulate the immune response. So heavily involved in maintaining and eliciting an immune response. Here is a nice little synopsis of the white blood cells. You can see what they look like, what the percentage is, what their nucleus looks like, and then the function. Then also their lifetime and what are the main targets. So this slide is high yield. I'm not going to go over this. We just kind of went through this all together, but this is a nice little slide that you could print out and study from. Next up, the lymphatic system is heavily involved in immunity, obviously. So we're just going to take a few minutes here to go over the main components of the lymphatic system. So closely integrated, and all are linked to the hematological and immune systems. So lymphoid organs are merely aggregations of tissue. Primary are the thymus and the bone marrow. So those are primary lymphoid. I always think of bone marrow as number one because that's where pretty much all of these things stem from. Secondary is your spleen, lymph nodes, tonsils, Peyer's patches, which are in the small intestine. So they are sites of proliferation, residence, differentiation, and function of lymphocytes. So high yield, that is big for the lymphocytes, as well as the mononuclear phagocytes. So those are those monocytes and macrophages that we talked about. So there is, a basic picture of what the lymph system looks like. We have lymphoid tissue spread out all over the body. So let's take a look at the spleen, a major lymphopoietic organ, 25% of the total lymphoid mass of the body. We have the reticular endothelial system, can react and enlarge quickly after the onset of infection and inflammation. Function is to remove particulates such as opsonized bacteria, antibody-coated cells from the bloodstream. So a major cleaning mechanism. It filters blood-borne antigens, cleanses the blood through action of the mononuclear phagocytes, initiates immune responses to blood-borne macroorganisms, particular bacteria, destroys aged red blood cells, also serves as a reservoir for blood. So very important to the hematologic and immune system. So the spleen is concave. It's an encapsulated organ. It is about the size of your fist, and it's located in the upper abdominal compartment. The compartments contain, we have connective tissue, strands of connective tissue called trabeculae. So you can see that here. And then we have, that's what's divided into categories. And we have splenic pulp. We have white and red. The white pulp is embedded within the red pulp. The spleen is interlaced with many blood vessels. That's their ability to store the blood. Blood that circulates through the spleen comes from the splenic artery, which branches from the descending aorta and re-enters circulation through the splenic vein and into the portal vein. So arterial blood enters the spleen, first encounters the white pulp. This is the white pulp in here. So you can see the arterial blood supply comes in, white splenic pulp, and that consists of masses of lymphoid tissue containing macrophages. So this is the white pulp is lymph tissue. And then we have macrophages and lymphocytes. And then we get T cells. We also have lymph follicles, and they have the B cells. And this is more peripheral. This is the chief site of immune function within the spleen. So we'll have blood-borne antigens encounter the lymphocytes, initiating the immune response. And then we get conversion of lymphoid follicles into germinal centers, where the B cells will then proliferate and differentiate during humoral response. So we get differentiation of the humoral. And that's just that, making sure we get the memory B cells and then antibodies. So the red pulp of the spleen, so that's up here. So some of the blood that enters the terminal capillaries continues through the microcirculation and enters the highly distensible storage area of the venous sinus in the red pulp. So this is more of a storage. So the red pulp is more of a storage area. This is capable of storing up to 300 milliliters of blood. Sudden reductions in blood pressure cause the sympathetic nervous system to stimulate constriction of this, and then it results in an expulsion of the blood into the circulation, and we get up to 200 milliliters of blood into the venous circulation, which actually brings it up about 4%. So high yield when we have a drop in blood pressure. So the endothelial lining of the venous sinuses is discontinuous, meaning that there's a gap between those endothelial cells, and therefore it's extremely permeable to the blood cells that are entered in circulation. The red pulp contains loosely interconnected macrophages and the principal site of splenic filtration. So there's another way that the immune system, we have macrophages within the spleen, and they easily phagocytize old, damaged, dead blood cells of any kinds. Chiefly, this is where we get the erythrocyte cleaning, as well as microorganism, macromolecules, and then particulates of debris. The spleen is not necessary for life. However, splenic absence for any cause has secondary effects on the body. For example, we'll get leukocytosis. Often occurs after splenectomy, suggesting that the spleen has some control over the rate of proliferation of the leukocytes in the bone marrow and their release into the blood system. And then circulating levels of iron may also decrease, so there must be some role of the spleen in the role of iron as well. The immune response to encapsulated bacteria is also then severely diminished, so huge, and that is items such as Haemophilus influenzae, Streptococcus pneumoniae, Neisseria meningitis. All of those would put the patient at higher risk for disseminated infections and sepsis. So here is just alterations in splenic function. So there can be multiple ways that we get problems within the spleen, such as cirrhosis, heart failure, and that's related to, remember that we go into the portal vein, so if we have any problems there, we can have a congestive issue which backs up into the spleen. We can have some malignancies in there, such as acute chronic leukemias, polycythemia vera, multiple myeloma can affect splenic function. Inflammation, such as sarcoid or lupus, hematologic states, this is basically hypersplenic, such as a hemolytic anemia or sickle cell in children. Non-malignant infiltrated diseases, amyloid and lysosomal disease, and then infections such as mono and CMV. The lymphatic drainage and nodes. So these are collections of interstitial fluids from the tissues and transported to the lymph through the vessels. They will increase size when they're in response to an infection, obviously. So the lymph nodes are distributed throughout the body and provide filtration of lymph during its journey through the lymphatics. Each lymph node is encased in a fibrous capsule, branches of which are called trabeculae, extend upward in partition to the node into several compartments. We have reticular fibers of connective tissue, also dividing the compartments into a meshwork. So we have the outer cortex. So outside is always the cortex. And we have the inner, which is the paracortex. And then we have an inner medulla area. Lymph enters through multiple small afferent lymphatic vessels into the subcapsular sinus just beneath the capsule, drains into the cortical sinuses, and then into the medullary sinuses. The lymph it's collected, leaves the node by way of afferent lymphatic. So afferent in, efferent out. So again, part of the hematologic and immune systems, primary site for the first encounter between antigen and lymphocyte. Lymphocytes enter the lymph node from the blood through the postcapillary venules by means of diapedesis across the endothelial lining. B lymphocytes tend to migrate preferentially to the nodes in the cortex and medullary, where T lymphocytes migrate to the paracortex. So we have B sites more on the outside, and then T sites are more on the inside. Macrophages reside in the lymph node and help filter that lymph of debris, foreign substances, and microorganisms. So the macrophages are going to be more in this cortex region as well. Also, we have dendritic cells, which remember that the macrophages and dendritic cells are big for antigen processing functions. So the reticular network is also providing an adhesive surfaces for trapping large numbers of phagocytes and lymphocytes and facilitating their organization. So they all kind of help organize each other. Thymus is next. So this is a bilobed lymphoid organ located in the superior mediastinum of the thorax. So that's the thymus right there. After puberty, it decreases in size, and it's small and fatty in adults after degeneration. This is the primary processing site and maturation of T lymphocytes. Remember, thymus, T lymphocytes, that's what they're named for. While they're in the thymus, the T lymphocytes do not respond to pathogens or foreign organisms. This is just a place that they get matured. The thymus also produces thymosin. It's a hormone that helps stimulate the maturation of the T lymphocytes in other lymphatic organs. The thymus gland will not function throughout a full lifetime, but it has a big responsibility when it's active, helping protect yourself against autoimmunity, and also plays a vital role in the endocrine system as well. So once you reach puberty, the thymus slowly starts to shrink and becomes replaced by fat. By age 75, the thymus is little more than a fatty tissue. So we have two major categories of thymus cells. They are the thymic epithelial cells and the thymocytes. The thymic epithelial cells are in this thymic cortex, which is the outermost layer of the organ, and that's what produces this thymocyte. Thymocytes are also called T lymphocytes or T cells. So once the T cells have fully matured in the thymus, they migrate to the lymph nodes. And that's where they're going to encounter antigen-presenting cells and help with our immune response. Disorders involving leukocytes range from deficiencies in the quality and quantity of the leukocytes, which we call leukopenia, to increased numbers of leukocytes, which is leukocytosis. So we're going to take a look at these. Many hematologic disorders are malignancies, and many non-hematologic look at bone marrow issues, which affect the leukocyte production. When we talk about leukocyte and lymphoid issues, a lot of it is related to malignancies. So we will talk about malignancies a little bit more in the cancer section. Here tonight, I'm just going to talk about really the alterations in leukocyte function, which would be those quantitative leukocytosis, leukopenia. We'll spend a little bit more time on the cancers later on. So leukocytosis is a count higher than normal, and it can be caused by a variety of things. It occurs via normal protective responses to physiologic stressors. So that may be something like strenuous exercise. Certain medications may induce leukocytosis. And then we have infections, obviously. Emotional changes, temperature changes can cause it. Pregnancy, surgery, anesthesia, hormones such as cortisol. So pretty much when we're talking about leukocytosis, any type of stressor can cause, either a physiologic or a pathologic. Pathologic is related to malignancy or hematologic issues. The other thing, tissue necrosis, remember that we get an inflammatory response after we have necrosis, not apoptosis. So that is another one. We have something called a marginated pool, and we're going to take a look at this in a few minutes. And that is marrow neutrophils, including the bands, are kind of stored in this marginated pool. What happens is we have increased demand versus supply, and then we get a left shift. So we're going to talk about that in a few minutes here. High cortisol state, such as either a pathologic condition or the use of steroids, impairs leukocyte adhesion, leading to a reduce of the marginated pool. When we're looking at leukocytosis, you must always, if you suspect a infection, you need to get a differential. We usually assume that leukocytosis is increased circulating neutrophils. Your differential is going to confirm, as well as tell us if there are any other associated rises in your monocytes, eosinophils, basophils, or lymphocytes. So when we're looking at monocytosis, then we would be infection, hematologic, physiologic, bacterial endocarditis, tuberculosis, myeloproliferative disorders such as Hodgkin's disease, also big for that. If we're looking at eosinophilia, so allergy, infection, malignancy, certain drugs, so this would be asthma, hay fever, parasites, and then lymphoma. Basophilia, so this would be infections such as measles or chickenpox, myeloproliferative disorders like polycythemia vera or chronic myeloid leukemia. Some endocrine issues with basophilia we see with antithyroid therapy or myxedema. And then we get down to lymphocytic leukocytosis, which would be increased circulating lymphocytes. We see that with viral infections such as infectious mononucleosis, CMV. Other things would be syphilis, ALL, or CLL. So you can see here that really it helps us differentiate what is the condition that's causing the leukocytosis. So the leukomoid reaction is considered the shift to the left. All right, I'm sure you've heard providers talking about this. Shift to the left. So what is this? So this shift to the left is basically premature release of immature white blood cells in response to depletion of the mature white blood cells. Basically, your demand infection exceeds the supply. So we have all of those cells being released from the line. We get a lot of immature cells because they didn't have a time to mature yet because the demand is so high that they get released into the circulation prior to them really being matured. So we have that promyeloblast, we have a promyelocyte, myelocyte, metamyelocyte, and then a band neutrophil. Ultimately, we want to get segmented neutrophils because that means that it is optimal production, it's working, and it is mature. So what happens is we get release of these banned neutrophils, and that means that they are immature. Many diagrams present cellular differentiating and maturation from left to right instead of vertically. So ultimately, that's what it means by a left shift, is that we're going to the left side of the diagram on how we view cell differentiation. When you take a look at a white blood cell differential, so you will get the normal values. If there are bands present, it will say that there are bands or stabs present. So here's a shift to the left is what it looks like. So you will see the bands being elevated. Here is just kind of a synopsis. I already included that back on those other sheets, but this is what it looks like when we're talking about elevations in certain white blood cells. So next is leukopenia or neutropenia. So this is the decreased circulating neutrophils. When we're talking about levels, it's less than 1,500 cells per microliter in most clinical laboratories. Usually we're talking about neutrophils, and that's because they're the most abundant white blood cells in the peripheral. Mature neutrophils are called the PMNs, and that is related to their segmentation of the nucleus. We also can do an absolute neutrophil count, which is the number of neutrophils plus bands, and then we would basically times the white blood cells times the percent divided by 100, and we get the absolute neutrophil count. Obviously, this is big with your cancer patients. We do have degrees of leukopenia: mild, moderate, and severe. When we see severe leukopenia, we definitely think there's a bone marrow issue going on. Drugs can cause bone marrow suppression. Chemotherapeutic agents cause bone marrow suppression. Ionizing radiation causes agranulocytosis. There's lots of high death rates when we're talking about agranulocytosis caused by ionizing radiation. So when we're looking at that etiology of leukopenia, you're looking at is it inherited or congenital? And here are the most common kind of congenital disorders, such as benign ethnic neutropenia, familial neutropenia, or congenital neutropenia. Then we have acquired disorders, such as infection medications, nutritional, autoimmune, rheumatologic, and then we also have hematologic malignancies. Lymphocytosis is an abnormal increase in the lymphocyte count, maybe a transient infection or one of a number of benign or malignant conditions. Consider malignant proliferation versus reactive. Reactive includes viral causes such as CMV, mumps, rubella, influenza, bacterial pertussis, cat scratch fever, toxoplasmosis. Others would include a drug hypersensitivity reaction, stress, or a thymoma. This is rare in acute bacteria. It is more common in viral, especially EBV, Epstein-Barr virus, which is the causative agent in mono. Lymphocytopenia is an abnormal decrease in the lymphocyte count. This also may be transient, related to maybe a neoplasia, immune deficiency, or we can get destruction related to some drugs, viruses, or radiation. It can also occur in individuals for no apparent reason. Other conditions associated with lymphocytopenia include lupus, TB, aplastic anemia, high cortisol state, and then cytotoxic chemotherapy or radiation. Another big one would be HIV. So when we're talking about the lymph system, we get lymphadenopathy. So this is basically enlarged lymph nodes. What you look at is size, consistency, fixation, painful versus painless. Inflammation of the lymph node is hyperplasia of the regions within the node, and it's directly related to an immune response. We look at whether it's localized or generalized, and that leads us to differential. So many potential causes. Biopsy is sometimes the best way to reach a definitive diagnosis, but it should be used very cautiously or judiciously. Your history focused physical exam leads to that differential, what is involved in addition to getting some lab work. So lymphedema is one of the big ones. So this is that chronic progressive swelling of tissue with the protein-rich fluid. It is usually developmental, which we classify as primary lymphedema, or acquired, which is secondary, disruption to that lymphatic system. The extremities are most affected, followed by genitalia. If it is a nematode infection, filariasis, which is endemic to Africa or Asia, malignancy is the main cause of secondary lymphedema and cancer-related treatments. And of this, breast is the most common cause of lymphedema for breast cancer. So your etiology and epidemiology, again, cancer treatments, especially breast, lymph node dissection, which is common with breast cancer. You can get lymph node dissection with some other cancers. Lymphatic hypoplasia, so is there something wrong that you have hypoplastic tissue? Parasitic nematodes, injury to the lymph. It does account for 140 to 250 million worldwide. Primary lymphedema is usually congenital and developmental, but it is still quite rare. So what's interesting is it's a male to female ratio is equal, but we have more preponderance of male presentations in infancy and more females in adolescence when we're talking about the children. And secondary lymphedema is usually secondary to malignancy. The pathophysiology of the lymphedema is basically the lymphatic system is supposed to return that interstitial fluid and proteins back into the circulatory system. There's particulate matter, microorganisms are filtered, immunologic response, we just talked about the lymph system. There's dysfunction of the channels or nodes leads to lymph accumulation into the superficial interstitial space. So we're basically altering your oncotic pressure and it filters out. We have lymphatic stasis and we have fat hypertrophy with associated thickening of the subcutaneous tissue, as well as continued immunologic dysfunction related to a non-functioning lymph tissue. We have interstitial proteins that cause inflammation and fibrosis, leading to a cycle of further damage. It will clinically present as painless unilateral swelling of the extremity or genitalia. You will have a positive stemmer sign. A positive stemmer sign, so basically you can't pinch with your thumb and index finger. And this is a sign that was described for the toes. A trainer observed the demonstrated phenomena on one part of the body. If you have a negative stemmer sign, it does not exclude lymphedema. You also have limb heaviness or weakness, non-pitting edema, classic, and then you will have those skin changes remain related to those inflammatory changes that happen. What you will test it with is a lymphoscintigram, and this is one of the most accurate tests for lymphedema, and it's a radiographic image taken with TC99 labeled antimony, sulfur, or albumin injected into the web space, and then they obtain images, and then it will basically state that there is dermal black flow, delayed or absent transport, and then lack of visualization of the lymph nodes. You also can get MRIs or CTs of the affected limb, ultrasounds. You can do a blood smear. You would be looking for those nematodes. And then genetic testing if you're looking at a congenital issue with that child presenting. So genetic testing should be ordered in anybody with primary lymphedema.